Dr. Sandeep. Welcome, Sandeep. He's talking about the heart failure in non-cardiac surgery patient.
Well, thank you so much. I think it's a tough act to follow, Dr. Farag. I will try my best. I do know it's pretty late out there, so I will try my best to go quickly. I'm just trying to get the PowerPoint to work here. Well, thank you for the invitation. And today I'm going to talk about updates on management of perioperative heart failure. So I'm going to start with the question for the group. We have Mr. Smith. He's a 70-year-old gentleman. He's coming in for a preoperative visit for a robotic prostatectomy. He had an MI 2 years ago, presented to the hospital in cardiogenic shock, and was taken up for the 3-vessel CABG. Currently, he can play double tennis comfortably. He has 2 questions for us. How bad is my heart failure right now? And what is my risk of dying during or after surgery? So through this presentation, we will try to answer Mr. Smith's question. The objectives today would be to figure out how to define, stage, and classify heart failure, to discuss perioperative concerns related to the 2 new medications that have been added, sacubitril valsartan and ivermectin, and finally, how do we go about constructing a perioperative anesthetic plan for these patients? So just before we start, why is heart failure so important? Looking at the scope of the problem, currently about 7 million Americans are walking around with heart failure. This number is going to go up to about 8.5 million, with the majority of the increase coming in the population which is 65 years and older. And why is that important? It turns out heart failure is the commonest cause of hospital admission in this age group. And furthermore, about 50% of these patients may not survive beyond 3 years after their first index hospitalization. When we looked at the data, in 1999, the risk-adjusted 1-year mortality from heart failure was about 32%. And as you can see, in 2008, it's not changed much, even though the heart failure hospitalizations fell by almost 20%. Now, is this unique to the North American population? In 2011, Sean Van de Pen, he's a cardiologist from Canada, and he's very active in the field of heart failure. He looked at a data set of about 40,000 patients from Canada. And what he was looking at, or what he was trying to answer, was that do patients who have heart failure, do they have a higher perioperative mortality compared to folks who have just coronary artery disease? And surprisingly, what he found was that if you look at the 30-day perioperative mortality, which is in blue, it was almost 4-fold higher for folks who have ischemic or non-ischemic heart failure compared to those who have stable coronary artery disease. This was replicated in the American population. The authors looked at a cohort of patients who were 18 years and above, and the data was picked from the National Inpatient Sample. This is one of the largest inpatient registries in North America. And they looked at a time period of about 3 years, spanning from 2012 to 2014. 21 million surgical hospitalizations were looked at, and about 4.9% of patients had heart failure. The authors were primarily interested in in-hospital mortality. And what they found was that a patient who comes with any diagnosis of heart failure has about a 4.8% chance of dying during the perioperative period. When they present with acute heart failure, this goes up to about 8%. Now, why are we talking about this? When we look at the American Heart Association guidelines regarding preoperative workup for folks who are presenting for non-cardiac surgery, a lot of the stress is on coronary artery disease. And this data begets the question whether the conversation needs to shift And do we really need to focus on people who have heart failure? Heart failure, turns out, is very expensive to manage. So in 2010, America was spending about $30 billion taking care of people with heart failure. And this amount is expected to go up to about 70 billion by 2030. Now, to put this in perspective, there are about half the countries in the world have a gross domestic product that is less than $70 billion. And to spend so much on heart failure, in a way, is insane. So what are we trying to get at? The prevalence of heart failure is increasing. And for us, that means that we will be taking care of these patients more often as we move into the next decade. These patients are also more likely to die. And the cost of taking care of these patients is increasing in leaps and bounds. I'm going to shift gears out here, and we're going to look at how have we been talking about heart failure over the last couple of decades. So we do talk about heart failure either temporally, acute versus chronic. We can talk about it anatomically, whether it's left-sided heart failure or right-sided heart failure. We can look at the phase that's affected, systolic versus diastolic, or we can talk in terms of etiology, ischemic or non-ischemic. In 2013, the American Heart Association decided that it was high time that they got together and provided a common framework on how we should be talking about heart failure. 2017 saw a focused update, and in fact, this week they released the new updated guidelines on Thursday. So how are we talking about heart failure now? What has been suggested is to use the ejection fraction as a characteristic of heart failure. So we now talk about heart failure as heart failure with reduced ejection fraction, where the EF is less than 40%, or as heart failure with preserved ejection fraction, where the EF is 50% and above. In the past, these were referred to as systolic versus diastolic heart failure. Now, to emphasize on a given point is that, even though we talk about systolic and diastolic heart failure, it's important to realize that somebody who's walking around with systolic impairment also is walking around with a substantial diastolic impairment. For example, if you look at the macro markers of heart failure, such as stroke volume or EF, they may be reduced in EF, in heart failure with reduced EF. And they might be normal in patients who have heart failure with preserved EF. But when you start looking at finer measurements, such as longitudinal strain, end diastolic pressure, and tau, it seems like both heart failure with reduced EF and preserved EF behave in the same manner. So what's important to realize is that these are not as different as we think they are. All right. So the definition or the characterization of heart failure has changed. What about the classification? So I'm going to refer back to the famous New York Heart Association classification. This was first proposed in 1928 and last updated in 1994. Despite all these years, it has stood the test of time. Everybody's familiar with it. The question is there a problem with this classification? So a couple of things come to mind. The first is that it's very subjective. What is normal activity is left, for the practitioner to decide. What is normal activity for a 20-year-old would be very different from what a normal activity would look like for an 80-year-old. The other problem with NYHA classes is that folks can jump between classes very rapidly. Let's take the example of Mr. Smith. When he came to us with an MI 2 years ago, his NYHA class was 4. He was in cardiogenic shock. And now he can play tennis comfortably with some shortness of breath. And we can probably peg him at NYHA class 2. So how does this represent the progression of his heart failure? It doesn't. What it does is it tells us in this snapshot of time how bad his heart failure symptoms are. For example, if Mr. Smith leaves the office, goes to the bar, gets a couple of drinks, or fluid overloads himself, he can quickly jump from NYHA class 2 to 4. So what's happening is, depending upon the preload and afterload conditions, patients can jump between classes very rapidly. So to overcome this deficit, where the NYHA class fails to actually reflect the progression of heart disease or heart failure, the American Heart Association proposed staging of heart failure. The staging goes from stage A all the way to D, with stage A being representing patients who are at high risk for heart failure, but currently do not have any structural changes in the heart or symptoms of heart failure. So this would be somebody who has hypertension or diabetes or is currently smoking. When we follow this patient over a couple of years, they are eventually going to develop some LV remodeling from the hypertension, diabetes, and smoking, and might start showing structural changes in the heart, but without any signs or symptoms of heart failure. So their LV strain might be compromised, but they are still not symptomatic. As we follow them over a couple of years, now they might start getting symptomatic. And with the smoking, with the hypertension, now there's more calcification in the heart. The aortic valve might start getting affected, and stenosis might start setting in, along with shortness of breath and a decreased exercise tolerance. And then if we follow them again over a couple of more years, they might end up with refractory heart failure or end-stage heart failure. And the beauty of the staging is that patients cannot revert back or jump from one class, from a progressive class to a regressive class. So somebody like Mr. Smith, who had an MI, would be qualified as a stage C patient with an inherent risk of progressing to stage D. But Mr. Smith is never going to jump back to being stage B or stage A. The staging also presents suggested therapies for each stage of heart failure. With, of course, stage A, the paramount treatment being adopting a healthy lifestyle, and perhaps even starting ACE inhibitors, ARBs, and statins. Stage B folks, in addition to the guideline-directed medical therapy, may be candidates for revascularization, valvular surgery, or even placement of an ICD. In stage C patients, along with all these guideline-directed medical therapies, there may be a chance for surgical intervention for remodeling the LV versus doing some valvular surgery. And finally, in stage D patients, we can go a couple of routes. They can either be candidates for heart transplantation. They could elect to get a temporary or a permanent mechanical circulatory support device. They could elect to get started on chronic inotropic therapy, and that would be in line with palliative care and hospice. So what we know as far as pharmacotherapy for heart failure is concerned, currently we have 6 broad drug categories that are useful. And of these, barring diuretics, everything else has shown a mortality benefit. I'm just going to switch gears out here and talk about how does pharmacotherapy actually help in chronic heart failure. So it turns out as the heart starts failing, the body starts retaining fluid. There is also increased norepinephrine and vasopressin levels initially that lead to vasoconstriction. And the renin-angiotensin load leads to adverse remodeling. So most of our pharmacotherapy actually takes care of these detrimental concepts. The diuretics will help unloading the volume off, as well as causing a decrease in sodium. And the beta blockers and ARBs and ACEs help with vasodilatation. So today, if we look at how a stage C NYHA class 1 to 4 patient might be treated, all of them should be on an ACE inhibitor, ARB, and a beta blocker. And then depending upon their volume status, their ethnicity, as well as their kidney function, we add on other medications such as diuretics, hydralazine, as well as aldosterone antagonists. In 2017, the American Heart Association came up with a focused update to introduce 2 new medications. The angiotensin receptor neprilysin inhibitor, or as a short form ARNI, which was sacubitril valsartan, and the inhibitor of the sinoatrial pacemaker modulating funny current, ivabradine. We're briefly going to talk about how these medicines work and how they're so different from what we have right now. So going into ARNI, before we jump into it, I want to draw your attention to the endopeptidase neprilysin. So neprilysin is present in the body and it degrades all the things that actually cause vasodilatation, loss of sodium, and loss of fluid. So the idea behind the ARNI was, what if we introduce a neprilysin inhibitor? That way we can actually increase the plasma levels of ANP, BNP, and bradykinin that will help with vasodilatation and loss of fluid. And that worked really well. The only caveat being that neprilysin also degrades angiotensin II. So what was happening is that once we inhibited neprilysin, the levels of angiotensin II were going up and the vasoconstriction was predominating. Therefore, we added the ARB valsartan to it so that we can actually counteract the effects of angiotensin II. So therefore, sacubitril and valsartan are always given together. You might have heard it from its trade name. Its trade name is Entresto. So right now, the indications for use of an ARNI include heart failure with reduced EF, as well as anybody who's in class 2 or class 3 heart failure. Contraindications are very similar to ACE and ARMS. Anybody who has angioedema or have a known hypersensitivity to ARMS or ACE inhibitors cannot be on an ARNI. What about ivabradine? How does that act? We are all familiar with the action potential of the SA node. And as you can see, the SA node, the hyperpolarization phase or phase 4 leads to spontaneous diastolic depolarization. Now, this is mediated by something called the funny current. It's an inward sodium and outward potassium current. So what ivabradine does is it goes and blocks the funny channels and therefore delays the upstroke in phase 4. And consequently, what happens is the heart rate decreases. Now, how it differs from beta blockers is that it does not compromise inotropy. So current indications for ivabradine are a heart failure with reduced EF for 35%. Patients need to be on a maximally tolerated dose of beta blocker, and despite that, have a heart rate greater than 70 beats per minute. It does have a couple of contraindications. The list is a bit broader than that of the ARNI. Because it causes profound bradycardia, it cannot be used in folks who already have bradyarrhythmias. The other issue with ivabradine is that it does prolong the QT interval. So folks who have a baseline prolonged QT interval do get elevated to a high risk for torsades when they are on ivabradine. The current suggested paradigm after introduction of these medicines is that folks with stage C heart failure do need to be on an ACE or ARB and a beta blocker. And if they can tolerate these doses, the ACE and ARB needs to get switched, to an ARNI. And ivabradine is added only if the heart rate is greater than 70 beats per minute on a maximally tolerated dose of beta blockers. So what do we do with these medications perioperatively? Now, data is very scant for both these medicines. As far as sacubitril valsartan is concerned, the AHA recommends that perhaps it may be feasible to continue it perioperatively. There are other societies and expert opinions that suggest that it's best to stop at 24 hours before surgery and then restart at 48 hours after surgery. Ivermectin, we talked about how it prolongs QT and therefore it needs to be avoided, or drugs that actually prolong the QT need to be avoided when a patient is on ivermectin. The other thing is that ivermectin is also metabolized by CYP3A4. So if patients are on these inhibitors, then they are actually at risk for developing ivermectin toxicity. In the OR or the perioperative world, the medicines that we might be using that actually might have an interaction include amiodarone, diltiazem, and verapamil. So ivermectin toxicity is very resistant to atropine, and suggestions include starting patients on epinephrine infusions or moving as quickly as possible to a transvenous pacemaker if ivermectin toxicity is suspected. I'm going to move on and talk about how to construct a perioperative plan for heart failure patients. Now, we are going to encounter these patients in various settings for various types of surgeries, elective, urgent, or emergent, and they may be in different categories of heart failure when we actually encounter them perioperatively. So how do we go about taking this information and making it and constructing a plan? So what we suggest is a 10-question paradigm. The first question being, what kind of heart failure does the patient have? And out here, we type the heart failure based on EF. We figure out what is the NYHA class, stage the heart failure, and we always talk about, is there a differential diagnosis? Can this not be heart failure? Things that might mimic heart failure, shortness of breath, reduced exercise tolerance include anemia, as well as neuromuscular diseases, or even obesity. So it's important to actually look at the history and physical examination and corroborative findings, including what's going on with the EKG, echo, and brain natriuretic peptide levels. It's also important to figure out what kind of heart failure syndrome does the patient have. And now, surprisingly, despite having 3 iterations of the guideline, these definitions still remain very arbitrary. So stable heart failure is defined as somebody who has stable symptoms for at least 1 to 3 months. Acute or decompensated heart failure is somebody who has exacerbation of symptoms requiring hospitalization, and that typically manifests as dyspnea with or without shock. New onset heart failure is somebody who's never been diagnosed with heart failure. He comes to you in the pre-op clinic, and you actually using the history, physical, as well as the echo, diagnose heart failure. And finally, there's advanced heart failure, which is somebody who's always an NYHA 3 or 4 functional class, despite being on guideline-directed medical therapy, and has had more than 1 unplanned hospitalization over the last 1 year. Now, it's important to note that while it may seem that a stable heart failure patient may do well perioperatively, there are multiple triggers that might quickly turn a stable patient into an acute or decompensated heart failure patient. And common triggers for this include medication non-compliance, pain, bleeding, uncontrolled diabetes, and either new onset ischemia infarction or arrhythmia such as AFib. All right, sorry. The third step is to figure out what kind of guideline-directed medical therapy the patient is actually on. And we talked about the 6 classes of medications, as well as a possibility of having electrophysiological therapy, such as cardiac resynchronization therapy, or being on mechanical circulatory support. The good news is that, if possible, the idea is to continue all medications. Now, importantly, as the heart fails, it dilates. the ellipsoid LV turns into a spherical shape. The left atrium and the right atrium kind of expand and the volume increases. And all this stretches the conduction system. So these patients often develop atrial fibrillation. And then the question becomes, do we need to bridge perioperatively? So as you know, for atrial fibrillation, patients can be on warfarin or the novel anticoagulants, the factor 2A and 10A inhibitors. They need bridging only if they are on warfarin and if they meet one of these 6 criteria. They need to have a chance to score of 5 or more. They probably need to have a mechanical mitral aortic valve. What happens if they are on the novel anticoagulants? How many days prior to surgery do we stop? Now, this depends upon the half-life of the agent, upon the renal function, what the creatinine is and the clearance looks like, and finally depends upon the risk of bleeding of the surgery. For most patients who have a low risk of bleeding with a normal creatinine, these agents can be safely stopped 24 hours before surgery. For those who are at high risk of bleeding and have CKD stage 3 or more, you might need up to 72 hours of stoppage before you can proceed with elective surgery. What happens if these patients come for emergent or urgent surgery? Well, for warfarin, we do have PCCs as a suggested reversal. For dabigatran or Pradaxa, we can use this new drug called Praxbind. And finally, for the factor 10A inhibitors, apixaban, such as Eliquis, we can use andexanet or even the 4-factor PCCs. The fifth question is, is there an electrophysiological therapeutic device, such as a pacemaker or ICD? And is there an assist device, such as an LVAD or an Impella? As far as the electrophysiological devices are concerned, we really need to know what was the indication of placement, the battery longevity, and if any leads have been placed in the last 3 months, which might interfere with placement of a central line. Importantly, we also need to figure out if the patient is pacemaker dependent. As far as LVADs are concerned, I don't have time to talk about it. But importantly, what I've found that trainees always think that if there's an LVAD, we don't really have to intervene. But even with LVADs, the patients can be hypotensive and we may need to intervene. And hypotension is defined as a MAP of less than 60 in this patient population. And depending upon how the LVAD flows look like, the interventions might differ. Importantly, I want to emphasize that if somebody gets a new RV MI, develops tamponade, PE, or a pneumothorax, all this will actually interfere with RV function, and the compromise in RV function will affect the LVAD functioning. So it's important to look at the patient as a whole, even though they might have an assist device. So how can we apply our 2014 perioperative cardiovascular evaluation guidelines to this patient population? What is important to realize is that as the heart failure syndrome progresses from an asymptomatic stage to a symptomatic stage and finally to an end stage, the mortality jumps phenomenally. And in fact, the risk of major adverse cardiac events might be better delineated in this population by adding BNP measurements to the mix. Commonly, we use the revised cardiac risk index to stratify risk of mortality or death in these patients. Now, normally the death or the mortality rate after non-cardiac surgery should be less than 2%. But as we've seen from Sean Van de Pen's article, as well as the National Inpatient Sample article, that in these patients, the mortality can be as high as 9%. And therefore, we need a better way to stratify the risk in these patients. So what's suggested is to add BNP measurements to RCRI or simply use the American College of Surgeons NSQIP surgical risk calculator. Unlike the RCRI, which is based on 6 factors, the the American College of Surgeons calculator has about 21 factors which cannot be calculated at the bedside. So we do have to go online to their website to do this. All right, so the current guidelines from AHA for preoperative evaluation is very focused on picking up folks who have coronary artery disease and who may need intervention for coronary artery disease, even if they were not coming in for surgery. It goes through about 7 steps. As you can see, the risk of major adverse cardiac events is delineated using RCRI. And if they're an elevated risk, we talk about, how is the functional capacity? What are the METs? And if the METs are less than 4, we might consider referring them to a cardiologist for further testing. Now, every institution, because there are no, there's not a guideline from AHA regarding heart failure patients, I'm presenting what our institution does. So whenever a patient comes to us for preoperative evaluation for non-cardiac surgery, we tend to assess what is the heart failure syndrome. If it's stable heart failure, we follow the AHA guidelines. If we diagnose new onset heart failure, or we feel that the patient is actually in acute decompensated heart failure, we refer them to the cardiology department for them to actually get on or optimize their guideline-directed medical therapy. And then we look at them after about 3 months to see if they are stabilized. If yes, we just follow the AHA guidelines. Now, if folks come with advanced heart failure, then we do need to involve the heart failure team. Heart failure team is a specific team that consists of a cardiologist, cardiac surgeon, an anesthesiologist, and a bioethicist. And the idea there is to actually talk about, is this surgery even required? And is there any other route that we could pursue so that the patient can have a meaningful life? Finally, what kind of monitoring do we need? Well, in addition to standard ASA monitoring, what is suggested is if we are encountering patients who are unstable or have advanced heart failure syndromes, we perhaps should move on to more invasive monitoring, including placing a PA catheter or TE in emergency situations. Now, it's important to realize that a stable heart failure patient, let's say Mr. Smith, who's coming in for his robotic prostatectomy, he might quickly develop or become unstable during the course of surgery, either because of bleeding or because of going into AFib with RVR, things that might change the situation very rapidly. So what that means for us is that we need to be fluid. We need to be ready to actually upgrade our monitoring once the patient becomes unstable. Does the choice of anesthesia affect outcome? There are no large-scale studies that suggest that neuraxial anesthesia does better than general anesthesia. In fact, anybody who has acute or decompensated heart failure would probably benefit from general anesthesia because they really can't keep up with the work of breathing on a spontaneous mode. Lastly, what kind of blood transfusion triggers are we following in these patients? This is interesting because if you look at the community, chronic stable heart failure folks walking around, what we have seen is that data shows that if the hemoglobin is below 13 grams per deciliter, the risk of mortality goes up. And therefore, in the guidelines, they talk about managing anemia very aggressively in these patients. However, in the perioperative period, what small retrospective studies have shown is that whenever the hemoglobin is corrected aggressively, or we transfuse them when the hemoglobin is more than 8 grams per deciliter, the risk of mortality goes up. Again, these are retrospective and they are small studies. So we do have to take the conclusions with a grain of salt, sorry. So we tend to follow the ASA guidelines. Anything below 6 grams per deciliter definitely needs a transfusion. Anything above 8 perhaps may not need one. And anything between 6 and 8, it needs clinical judgment. Is the lactate going up? Are there new ST changes? Or is the patient symptomatic? Thank you. I'm wondering if you have any questions for me.
Okay, thank you so much, Dr. Sandeep. Just my camera is off. My camera is off. Yeah. Okay, now we have one question here about what is the best index or tool to estimate the cardiac risk for the patient coming for non-cardiac surgery. What is you mentioned about the natriuretic peptide. Is it enough, or we should do many other investigation as well?
So that's an interesting question, Dr. Yasser, because if you look at RCRI, the way the index was developed, it was developed in a cohort of ambulatory patients. And then it was externally validated, across the world. But the caveat being that this index that we have actually comes from an outpatient setting. So there is no specific index for heart failure patients, and the suggestion from at least American Heart Association is to actually try to use the American College of Surgeons NSQIP calculator, because it takes into consideration a lot more parameters than the RCRI does.
All right, yeah. And you mentioned about some medication, we can stop it, we can continue it. In patient coming with heart failure in ECE inhibitors or angiotensin receptor blockers, what do you think we should continue or stop? Because as you know, maybe in cardiac surgery, there is high incidence of vasoplegia or vasoplegic syndrome, and it may happen in non-cardiac surgery as well. So what do you think?
Absolutely. I think, so if you look at the guidelines from AHA, they talk about two things. The first thing is that if somebody is at risk for a lot of bleeding or vasoplegia, perhaps it's best to stop these medicines 24 hours prior to surgery. The only thing that they emphasize is that what they have seen is if there is prolonged stoppage of medicines beyond a week, that itself also adds to the risk of death. So the recommendations now are about we stop at 24 hours prior and we try to restart at 48 hours after surgery.
All right, yeah. There is question from Dr. Ahmed, but it's very complicated questions actually. Patient with heart failure, NIHA 4, urgent surgery, intestinal obstruction, unstable heart failure with ejection fraction 20%.
So it sounds like he's coming in cardiogenic shock. And, I agree with Dr. Ahmed that the mortality in cardiogenic shock can vary from 50 to 80%. So for such patients now, what we are trying to do is that when we identify them, we actually either put an impeller or a balloon pump prior to taking them up for non-cardiac surgery, so that we can actually support the heart without putting them on excessive doses of vasopressors and inotropes.
All right, yeah. You talked about the guidelines from the American Society, which is published 2013, but I think there is updated guidelines in 2017 as well, but it is almost the same. There is no great changes. And just I want to ask you in general, if the patient has decompensated heart failure intraoperative, what we should do?
So Dr. Yasser, that's a great question. So typically what we do is, everybody needs vasopressors and inotropes at that point to probably maintain the MAPs above 60, 65. So we use something called the VI score, the vasotrope inotropic score. And if it exceeds 15, we get cardiology involved really early so that we can upgrade to a mechanical circulatory support device, such as an impeller or a balloon pump, or even ECMO if the RV fails. So these patients are tough. And, as Dr. Ahmed said, the mortality is very high.
Dr. Ahmed Eid is asking about spinal and epidural. Is it a safe choice in patient with compensated heart failure?
That's a great question. So, when you look at the folks who have compensated heart failure, they are probably NYHA 1 to 3 classes. And most of them actually are hypertensive, despite being on guideline-directed medical therapy. So it's actually pretty safe to initiate neuraxial anesthesia, keeping in mind that anticoagulation should be stopped appropriately.
Yeah. There is no more question, Dr. Sandeep, and I am very happy to hear your lecture and hope you can join us again with a new lecture.